What about if the zonulopathy is more severe? Now, this is a case of ectopia lentis, and you could hand this over to the VR surgeons and they could do a vitreolensectomy, but I actually think this is unnecessary. This is a patient, is a monocular patient, and actually she's in her 40s, and therefore a better approach would be to do this from the anterior segment, because actually there is no vitreous in the anterior chamber, and you don't have to worry about any vitreous coming forward, really, if you're careful and you adhere to principles. So you can see the zonules here, which are stretched. We put some viscoat over here to tamponize this area, and some cohesive viscoelastic as well. And then, you can actually perform a capsulorhexis on this sublux lens. And again, you've got to center the capsulorhexis here on the lens, not on the pupil, obviously. And then once you've completed the capsulorhexis, which actually happens in a routine manner, you'd be surprised how much strength these few zonules still give you in terms of when you're doing your capsulorhexis. So we then carry out hydrodissection, and in this case we attempted to prolapse and did prolapse the lens out of the bag a little bit, put up a couple of iris hooks on here just to support this area, and then we can carry out the hydrodissection, and then I'm just going to move forward just in the interest of time, and then you can get this lens out of the bag into the anterior chamber and phaco it relatively easily. At this point, you've got to be a little bit careful that the chamber doesn't collapse, so we go in with some viscoelastic just to pump up the anterior chamber, push the capsule back, and prevent vitreous prolapse when we come out with our phaco probe. And again, I'm going to use a Simcoe here because I think this is a little bit more gentle on the capsule, particularly when you've got these sort of zonular issues. So we'll just move forward here. Now we've got the cataract out. The next thing to do here is then to fixate the bag to the sclera, and we're going to use a tension segment here, and we make a mark a couple of millimeters back from the limbus, make a groove, and then we put the tension segment into the eye, and then we use a Gore-Tex suture, A2 Gore-Tex suture, which we pass through the eyelet and then dock it with a needle on the other side here. Just move that forward. And that's using the MSD micro holding forceps to dock the needle. And then we pull that through, and once we've got that through the eyelet, getting the second one through is relatively easy because we're going on the outside. So you end up with a loop of Gore-Tex around the eyelet of the segment, and then you can pull that into position, and we'll just get, there you go, and that pushes pulls the lens, the capsular bag, into a more central position. We tie that off with a couple of slip knots, put a capsular tension ring in as well for circumferential support of the zonular of the capsular complex, and then we place our intraocular lens into the capsular bag, and then we finally tighten this off once we're happy with the position of the lens. And this patient did very well and ended up with 6/6 vision unaided without going into the vitreous cavity.